Okay, good afternoon, everybody. Nice to see so many people on this meeting. First of all, let me just again thank the ECHO team from New Mexico, University of Albuquerque, and also the ECHO team from India that make these sessions possible. As you know, these Gecko Fellows meetings run every Monday at 4:30 Central African time. The chat will be open for questions, so if you've got any questions, just post them in the chat and we'll follow up on those. It's really a pleasure for me to introduce Dr. Gercois Human. He's a consultant radiologist and interventional radiologist here at University of Cape Town and Groote Hospital. And he's going to give us an overview of radiology that I think all of us can benefit from. More and more nowadays, we need to sort of be amateur radiologists when we deal with HPB diseases. So Gercois, over to you.
Hi, good afternoon, everybody, and thanks for having me. I'll be sharing today a bit on quite a topic I came across in the recent literature of radiology. And it's all about pancreatic duodenal groove. And I'll just go over what it is and then basically focusing on the spectrum of disease and some imaging findings of that. So yeah, let's just jump into it. So my first, I'll just go into a case that we had recently. It was a 62-year-old male presented with a day of abdominal pain and vomiting. And then on EOS, there was negative for biopsy. So I'll just scroll through the angiogram imaging on the CT. And as you can see, it's a very bright contrast in aorta and also the celiac axis already there. And as we come down, we start seeing the pancreatic head around about there. Still not really seeing anything specific. We are still seeing some low density in this pancreatic duodenal groove region. And then as we come lower down, we can see this just a focus of hyperintensity of contrast, which then subsequently disappears. So we definitely know that it's just situated in this region. And then just the surrounding low density around that, which could be edema, could be inflammation, nothing other than that. Yeah, so the patient, this is just a coronal imaging of a lip, and there we can see that small little dot just situating there. It's not a vessel, it's something on its own. And just to, the patient had an angiogram. The catheter is now situated in the celiac, in the SMA, the superior mesenteric artery, and then just to correlate it with the CT, just to bring the imaging together. So this being the celiac axis on top, sorry, this is first branch of the SMA, and we are seeing the left hepatic and the right hepatic there, probably from retrograde filling, and then the dot in the middle, which is quite sinister, as a pseudoaneurysm. Just zooming up on that image, here we can see that this is the region of the pseudoaneurysm, and it looks like it's originating here from the inferior pancreatic duodenal branch, and that was subsequently coiled, and this was treated successfully in a patient that improved. So that's just sort of introduction of imaging findings that can happen in the pancreatic duodenal groove, and then just figuring out what it can be. So just firstly, the pancreatic duodenal groove, it's a complex region, as you can see. I mean, there's a lot going on here. And in this image, the pancreatic duodenal groove is depicted by this purple area. It is the anatomic space is then superior to the anterior pararenal space, so it's anterior to the pararenal space. It's bordered by the pancreatic head on its medial aspect, so pancreatic head on the medial aspect. The duodenal bulb is superiorly, so in this region, and then the descending duodenum at its lateral aspect, and then the transverse duodenum inferiorly, and we have the inferior, the inferior vena cava posterior, so posterior to this portal vein running alongside the aorta. So this is the regions that depict the pancreatic duodenal groove, and then there are numerous cell lines in this region, so it's quite a busy region. This being the ampulla with ampullary complex. So we've got the ampulla there. We've got pancreatic cells, duodenal cell layers, with all its different layers. There's also connective tissue, nerves, vessels running all through there. The three types of mucosal epithelium that join up and compose of the ampulla part is pancreatico-biliary, duodenal intestinal, and foveolar-like mucosa. And then the duodenal wall, as shown here, is composed of 4 layers: the mucosa, the submucosa, and then muscularis propria, serotia, and a serotia as well. There's also smooth muscle cells and interstitial cells of Cargill that exist in the muscularis propria. Okay, I'll just reiterate on that a bit later. So yeah, as you can see, all of these cell lines can basically create something in the duodenal groove and lead to pathology. Firstly, I'm just going to look at infectious, inflammatory, or mimics of cancer. And yeah, just firstly, this article mentioned the paraduodenal pancreatitis, commonly known as the groove pancreatitis. Not sure what exactly is the cause, but they esteem that it's ectopic pancreatic rest in the medial duodenal wall. Just wanted to show this is the imaging focus. So this, it looks like sheet-like crescentic thickening of this pancreatic duodenal groove. The medial duodenal wall will often be thickened, and you can even see cysts or small cysts in the medial duodenal wall. The caveat is that pancreatic adenocarcinoma can often mimic the paraduodenal pancreatitis, especially when it presents as an infiltrative process. So just some imaging of paraduodenal pancreatitis in a patient with known alcohol history or abuse, actually. Our first image shows this area of low density as depicted by these arrows. And on the lateral aspect, we've got this open arrow showing this is actually the duodenum. So this is just thickening, enhancement, and displacement of this pancreatic duodenal groove. And then the pancreatic head is being displaced laterally. And on the coronal image, we can see this rounded low density regions, which are the cysts in this pancreatic duodenal groove. In this is the MRI imaging in the middle and in the lower aspect. This being T2, we can see this rounded high signal intensity, fluid-like signal intensity regions with the cysts. This is an uncontrasted T1 image, and then on early arterial enhancement, you can see the contrast in the aorta. It's low signal, meaning it doesn't show early enhancement, but it corresponds to this region on the CT of the low signal intensity. Here we can see nicely that the pancreatic head is medial with the CVD looking quite normal, and then a thickened medial wall of the duodenum, and then on a later imaging, this actually started enhancing owing to what they would say increased fibrosis in this region, and this is a presentation of paraduodenal pancreatitis. Just some imaging features that saying that it might look very much like adenocarcinoma is that the carcinoma will be more infiltrating versus displacing. Especially your vessels and surrounding tissue would be displaced in pancreatitis rather than infiltrated. When you look at the duct that's being obstructed, there's an abrupt obstruction, and then there's usually complete obstruction of the duct distally, versus in pancreatitis, it's usually tapered with incomplete narrowing distally. So and then in the pre-stenotic duct, you will have severe upstream dilatation in pancreatitis, in adenocarcinoma, whilst you will usually have contour irregularity and side branch dilation in the pancreatitis. Both of these entities can give you a double duct sign, but as mentioned, you'll have abrupt caliber change and shouldering in the carcinoma instances versus tapered and smooth narrowing with minimal duct dilation at that region. Can even be incompletely narrowed at that area. Just some imaging showing the carcinoma. And on the left, we've got this enhanced contrasted CT imaging showing this hypo-enhancing region in the pancreatic duodenal groove with direct invasion of the medial wall of the duodenum, as indicated by the black arrowhead. On the right image, just as the coronal imaging show us this hyper-enhancing mass, which appears irregular, and here we can see again the irregular infiltration into the duodenum, and then also lymphadenopathy, low signal lymphadenopathy in the porta, which is an ancillary finding, which a pathological lymph node like this would make you think more of a carcinoma rather than a pancreatitis. More imaging of duodenal carcinoma on these axial and coronal images, and here you can see the hypo-enhancing mass with infiltration into the duodenum, and just very, very similar also encasing structures. And then here we see on this coronal images that abrupt obstruction of the CBD, as indicated by this white arrow arrowhead here. Peripancreatic collections, as you know, can also be in this region. So this can be anything from acute peripancreatic collections, which can then evolve into an encapsulated pseudocyst, or it can be acute necrotic collection, which you would see as heterogeneous non-liquefied material, and it will have an encapsulated Waldorf necrosis. They are usually, all you see will be the septae that will show enhancement, whilst the content of it will be quite heterogeneous or pseudocyst in nature, but often heterogeneous. So this is some complications of pancreatitis. In image A, we've got a pancreatic pseudocyst, which has a rounded hypoattenuating lesion within the medial duodenal wall. So this is actually in the wall of the duodenum. It effaces and the lumen of the duodenum, which appears as crescent shape, and then here we can see calcifications in the pancreatic head. So that's just alluding us to signs of chronic pancreatitis. And then on this is a different patient, which has a Waldorf necrosis, so quite a severe collection in this groove region. And again, we can see the duodenum being quite effaced and small. I mean, this was just the T1 imaging of that similar patient, showing the collection and the thick irregular wall of this Waldorf necrosis. In image D, we have a mass-forming pancreatitis. This is a fat sac image, and then we can just see expansion of the pancreatic head as indicated by the arrow. So this is all pancreatic head, and there was a mild irregularity of the pancreatic duct as indicated by the arrowhead, black arrowhead, and then the white arrowhead was showing that penetrating duct sign. So as in comparison with our adenocarcinoma, which didn't show an abrupt, this just has a smooth, narrow tapering as it courses through the region of pancreatitis. Duodenal inflammation, also in this region, shows it's usually due to a reactive process of external process, so either cholecystitis or pancreatitis in that region. Infections that can cause it is usually Mycobacterium avium intracellulare or cytomegalovirus in patients that are known with HIV or immunocompromised. Inflammatory causes that can cause duodenal inflammation, it can be from radiation, IgA vasculitis, which was known as Schwannoma purpura, or a Crohn's disease with quite a wide range of patients that presented like that. The imaging characteristics will be circumferential wall edema. On CT, edema would be indicated by low density, so hypodense, and an MRI would be typical characteristics of fluid other than T1 low with T2 high. So here we've got a patient with duodenal inflammation and known with Crohn's disease, and it shows this duodenal wall thickening with hyperenhancement as indicated by this black arrow. This is all duodenum, and this being the mucosa and hyperenhancement. And then to just say, note the extension of the edema at the inferior margin of the pancreatic duodenal groove as indicated by the arrowheads. And on image B was a patient with peptic ulcer disease, and it shows this duodenal wall thickening. Here we can see disruption of the lumen of the duodenum projecting into that pancreatic duodenal groove, causing all this low hypodensity, low density on the CT scan, indicating edema. So this relates to the case I just showed you. So duodenal ulcers is situated normally in the duodenal bulb, which is at the superior edge of the pancreatic duodenal groove. Ulcers might actually be quite occult and only become evident once they are, when they perforate. And this will be seen as a compilation of wall thickening. We'll see some fluid as indicated by low density, and then extraluminal air. In peptic ulcer disease, that perforated is the most common cause of normal of gas you will see in the pancreatic duodenal groove. These duodenal ulcers can actually erode into the pancreatic duodenal artery, causing a pseudoaneurysm. And as mentioned here, they can also cause colodocoduodenal fistulas. And on imaging, what you will see over and above this would be also pneumobilia. Not to forget about IgG4 autoimmune disease, which is a lymphocytic infiltration rich in IgG4 plasma cells. It's usually identified by mass-like inflammatory reaction causing fibrosis. The pancreas will have a sausage shape, so that's the term used for it. And in some instances, it will also have a peripheral rim-like enhancement on the delayed imaging. That's quite pathognomonic when you have a sausage shape with a rim-like enhancement, but you won't necessarily always see this. It is a multi-organ disease, is associated with sclerosing cholangitis, retroperitoneal fibrosis, or can even involve the kidneys, perioparenal. So interesting to know is that IgG4 will always involve the pancreas at some stage. It doesn't have to necessarily be in the beginning, but it can be throughout the disease. So yeah, just a second case we had was a 66-year-old female presented with abdominal pain and discomfort. And I'll just run through the CT imaging, and already you can see a well-circumscribed mass in this region of the pancreatic duodenal groove, compressing the IVC posteriorly. And here we can still see it at the inferior border. And then there was some duct dilation there. In the portovenous phase, it just becomes isodense to and slightly lower density than, yeah, isodense to the liver. So they weren't really hyperenhancement. And on MRI, it's also low signal intensity. You can appreciate some heterogeneity, but remains well circumscribed and compressing or displacing the structure surrounding it. It is in closely associated with the IVC, but it, just to keep that in mind. And on a coronal imaging, we can still see it very well circumscribed, slightly heterogeneous, but low signal intensity actually throughout. And this was actually a patient to present with a leiomyoma sarcoma. More benign imaging features there actually. So the next big topic is a primary groove neoplasms. So it's a groove neoplasms in the pancreatic duodenal groove. They are usually has origins of mesodermal, neurogenic or lymphoid tissue. Mesodermal, quite common fat-containing lesions being the liposarcomas, and then the smooth muscle being the leiomyomas or myosarcomas being the neoplasms. Looking at leiomyosarcomas and liposarcomas, the leiomyosarcomas tend to be quite aggressive. You can find that they have necrosis inside of it, and being this aggressive feature, these aggressive features, they will invade, usually invade the adjacent structures that would usually stand out from them. Whilst liposarcomas are more commonly known with calcifications, and 30% of them, they contain macroscopic fat, which you will see either on CT as low density, and on the T2 imaging and T1 it will be bright, and if you have a fat set, it will definitely suppress that and become dark. They also tend to be well delineated. Here we've got a patient, 47-year-old man, who was diagnosed with a leiomyosarcoma. It shows this very aggressive appearing lesion in contrast to what you guys saw on the case I just showed you. Got this low signal density lesion with infiltrating the duodenum. You can see similar density in the IVC, is indicated by this arrowhead. It displaces the duodenum and the pancreas anteriorly. And in the coronal image, this actually just shows this lesion very nicely associated with the IVC and right renal vein. And this was a leiomyosarcoma originating intravascularly from the IVC and the right renal vein. Desmoid tumors are deep fibromatosis in the retroperitoneal region. They can either be sporadic or they're associated with a syndrome. And they are often triggered by trauma or surgery, most commonly known in females in the third decade, and is estrogen usually sensitive. On imaging, they're well circumscribed, they have homogeneous enhancement, although sometimes they can be infiltrating and invasive. And then the treatment, surgical has always been mentioned, but I think some people tend to do a watch and wait with radiation type of approach. Both are described. And then neurogenic tumors, they are usually highly vast. Also tumors of the retroperitoneum, usually found in younger patients, can either also be sporadic or associated with a syndrome. They are highly vascular, well-defined tumors with avid enhancement, often containing punctate calcification or hemorrhage or regions of cystic degeneration and necrosis. They are classically described, I think you will come across this as a light bulb bright on MRI T2 sequences. Some people will say, well, how bright is a light bulb exactly? as they, I'll show you on the next slide what I mean by that. And then often when they're at the time of diagnosis, there are often metastases in 20 to 50% of patients. So this is a patient with multiple paragangliomas, a 36-year-old with MEN2 syndrome. The left image was an arterial phase T1 sequence. It shows this white aspect is in the pancreatic duodenal groove. You can see there's quite heterogeneous enhancement, and then again displacing the pancreas anteriorly. In addition, the patient also has this very homogeneously enhancing mass situated close to or just inferior to the pancreatic tail. And on this was the T2 image, and this was described to be, or at least the brighter areas inside it, to be light bulb bright. And as you can imagine, it's not as white as this asterisk. So that's why they say how bright is a light bulb exactly. And then, but yeah, this was situated, and one can see quite well circumscribed these pancreatic paragangliomas in the retroperitoneum. This is a patient, 41-year-old man with a Schwannoma. This is well circumscribed, homogeneous in imaging characteristic, and it displays the duodenum and the pancreas anteriorly from the IVC and right renal vein, as indicated by this white arrow. So this is the Schwannoma. In younger patients, if it exists, one must just think of associations also with NF2. And as you just saw, it's a well-defined tumor. It has homogeneous enhancement. It is quite large, usually. And even if it's, when it's quite large, it has heterogeneous or cystic degeneration inside of it. It can also contain punctate calcification, so hemorrhage. And when it has when it has clinical findings of pain or enlargement on imaging, one would probably see that, or infiltration, one should consider that there are malignant transformations. But schwannomas are normally located in the paravertebral region. They're less commonly in these areas of the pancreatic duodenal groove, or and they usually are solitary and sporadic in occurrence. The last neurogenic tumors, neurofibromas, which are usually found isolated or in instances of NF1. And similarly, also well-defined round tumor, so the well-circumscribed lesions with low density. And the MRI appearance can vary depending on how much, what type of tissue is more or less prominent. But textbook describe them as centrally high on a T1 due to the nerve tissue, or peripherally they might be T2 high due to the myxoid degeneration. Lymph adenopathy in the pancreatic duodenal groove can be a manifestation of either primary lymphoma or metastatic malignancy. Lymphoma in this being the most common primary retroperitoneal malignancy that will cause the bulky lymph adenopathy or confluent coalescing soft tissue nodes. If it originates in the duodenum and pancreas, if the duodenum and pancreas are the primary sites of lymphoma, it can bulge into the pancreatic duodenal groove. But yeah, lymph nodes in patients with lymphoma will be normally homogeneously enhancing. It will also instantly display in display structures, and if they become really large, they can have central necrosis. It can also cause gastric or duodenal obstruction. This is a patient with metastatic lymphadenopathy and a patient known with breast cancer, incidentally. So on top left is a T1 arterial phase image. It's showing this hypo-enhancing ovoid mass in the pancreaticoduodenal groove. This is a DWI imaging that usually nicely shows dense cells, tissues with dense cells, either with malignancy or lymphadenopathy. And this shows this region of this lobulated mass in this pancreaticoduodenal groove. And in the bottom, this was just showing the FDG PET image showing bright uptake in this area, similar area or corresponding area in keeping with the metastatic nodal spread. Neuroendocrine tumors are rare, and when they are discovered, they're often non-functional and incidentally diagnosed during endoscopy. The common culprit in the duodenum is commonly gastronomas, of which a third can be functional. When one finds isolated hyperenhancing nodes in the pancreaticoduodenal groove, it may represent metastatic neuroendocrine tumors. So when one finds, what I'm trying to say is when one finds lymphadenopathy, hyperenhancing lymph nodes, which are isolated in this pancreaticoduodenal groove, one should consider that one should be looking for a neuroendocrine tumor and a gastronoma triangle. The triangle is the junction of D2 and D3 inferiorly, and then the intersection of the pancreatic head, pancreatic neck and body, and its medial border, and then the confluence of the cystic duct and the CBD superiorly. And then that's the areas one should scrutinize for a neuroendocrine tumor, as the hyperenhancing nodes in the pancreaticoduodenal groove are sinister, and one should be thinking of a neuroendocrine. Then looking for a cause. And if we see small hyperenhancing nodules in the duodenum and periampillary, that's how they will present as. So this is a patient, axial image, or arterial phase image showing an ovoid enhancing mass, which is this one, asterisk, anterior to the pancreaticoduodenal groove, and then this pancreatic head, and as you can see, being posteriorly displaced slightly. In the coronal image, you can see a small enhancing nodule, which is this, is indicated by this white arrowhead, and this proved to be a primary duodenal neuroendocrine tumor. It was subtle hyperenhancing lesion here in the left lobe of the liver, which was consistent with the metastases. Lastly, congenital lesions of the pancreaticoduodenal groove. So a duodenal diverticula is quite common. Up to 22% of the population in patients were found post-mortem. They're usually detected incidentally and is caused by weakness in the medial duodenal wall due to the entrance of the CBD or penetrating vessels. On imaging, you'll see them as rounded air-containing sacs, and these can complicate by either forming a diverticulitis, which you will see with stranding. They can perforate, we'll see extraluminal air, or there can be a bezoar formation or CBD obstruction, and this is known as Lemel syndrome. So this is some imaging on the left, A, B, and C, in a patient with Lemel syndrome. This ovoid heterogeneously enhancing periampullary, if you want, mass in this pancreaticoduodenal groove, which obstructed the CVD, as indicated by this white arrow. So you can see massively dilated CVD due to obstruction of this diverticulum with this heterogeneous content. And one can appreciate the black, a trace of gas within the lesion, and that's sort of the giveaway of it being communicating with the duodenum. This patient in the bottom right, image D, is one where there's gastric outlet obstruction. These black arrowheads is actually the contrast-filled stomach. And here we can also appreciate some contrast within the diverticulum. And yeah, so this was the black dots are gas within the diverticulum. The contrast is that trickled through from the stomach. And this caused massive gastric outlet obstruction. The last patient on the right is a bezoar pancreatitis. So this caused obstruction of the pancreatic duct, and this low density, very enlarged body and tail of the pancreas secondary to this bezoar causing obstruction. One should also not forget about enteric duplication cysts, which are true cystic lesions. And often when they're in the region of D2 and D3, they can extend into the groove. They've got a smooth, thick wall, and they have simple fluid on the inside, often depicting on ultrasound bowel signature. They can also cause biliary obstruction, pancreatitis. They can even tort and even be a lead point for intussusception. Type 3 colodochal cysts, if they're below the cystic duct, and they can often project into the duodenum or into the groove, which can mimic or keep one wondering. The best way, they say, one can just make sure is on an MRI, on a pactobiliary phase imaging. One can see the connection to the biliary system, and they can also cause biliary obstruction, can lead to pancreatitis, even rupture, and they do have malignant transformation potential, usually why they get resected. Annular pancreas is also something that can really throw you off, and it usually faces the groove. On imaging, on T1 imaging, the pancreas is hyperenhancing, and one will appreciate it surrounding the duodenum. And on T2 imaging, one can often see the pancreatic duct encircling the duodenum. On this image, what we are seeing here is the brightness is actually a patient who had positive oral contrast CT scan. So this axial image is actually the pancreas surrounding the duodenum. This is not a pseudoaneurysm, or this is not the duodenum. The duodenum is actually on the inside. So this is an annular pancreas mimicking a thickened duodenum. And what we're also going to appreciate is low signal is low density here is the CVD, the biliary duct. Then vascular lesions. So we've got lymphatic malformations that are benign. They can actually originate anywhere, but they are more common in the mesentery than the retroperitoneum. They're well-defined lesions, and the imaging will be multiloculated with either macro or microcystic regions. They have a thin border and thin setae, and they have fluid on the inside with very bright T2 signal, as I will show you now. So The black arrow is showing this very T2 bright region in the anterior pararenal space. There's some thin septae that we can appreciate. The wall is also quite thin, and it is interposed between the IVC, which is this one, and the descending duodenum anterior to that. The white arrow showing that. And this is the T1 image. I'm just showing the low signal intensity. So T2 bright, T1 low fluid. And this was an enhanced image. You can see the aorta is bright in this image, and there's no areas of enhancement within this region. So this is very specific for a lymphangioma. Then, as shown in the case previously, aneurysms and pseudoaneurysms. These are the culprit arteries, the gastroduodenal or the superior or inferior pancreatic duodenal arteries. They can rupture and then especially lead to fatal outcome in more than 40% of cases, especially with the cause was related to ulcer disease. If it was related to pancreatitis, they often bleed into the retroperitoneum and present with retroperitoneal hematoma. So one will either see massive upper GI bleed or melena, and that would make one think of that they are rupturing or busy rupturing. On imaging, they will show an outpouching of a vessel, and then the treatment as shown is often with catheter embolization, or one can even consider surgical ligation. And due to the rich collateral pathways between the celiac and the SMA, vascular reconstruction is not necessary unless one should just be aware of proximal stenosis. These imaging all showing various vascular aneurysms, A and B, this being the CT, and this angiogram shows this bulging out of the vessel. The white arrow showing a low density tract adjacent to the duodenum, the descending duodenum, and there's also thickening of this medial wall in a patient with known ulcer disease. On the angiogram, they are now in the celiac trunk. There's been a common hepatic artery. There's been a gastroduodenal artery down here. There was active contrast extravasation out of the gastroduodenal artery, and the black arrow is just showing some contrast seeping into the duodenum. Patient C is a different patient. There's actually a true aneurysm, and true aneurysms are often depicted with or as calcifications in eccentric calcifications in the wall due to their chronicity. That's that one, and then last traumatic lesions. Now they usually can either be from blunt or penetrating post-traumatic perforations, and they are usually seen with extraluminal air following the history of trauma. So one's history and clinical information plays a big role in making the diagnosis. Pancreatic duct disruptions, either from necrotizing pancreatitis or trauma, better depicted with either MRCP or ERCP. And mentioned previously the retroperitoneal hematomas, either from also trauma or pseudoaneurysm or aneurysm bleed, and they are always commonly treated conservatively in the retroperitoneum. So these are just some images showing trauma, patient A, and then patient, similar patient, same patient B and C. So A is just showing a non-contrasted CT image in a patient who had oral contrast to drink, and then showing this massive amounts of contrast in the peritoneum. And it appears to be originating here from the pancreatic duodenal groove. So indicating disruption of the lumen. In this patient, this is a big hematoma. This is a T1 image with heterogeneity, and then this being a T2 image. And one can see it's centered in the lateral wall of the duodenum. So this being the duodenum, and it wraps around this region of hematoma. Yeah. Lastly, one should just think about the regional, the structures surrounding the pancreatic duodenal groove, the larger organs, if one can put it that way. So if one, large lesions of the pancreatic head and uncinate process can extend into the groove. So one needs to know the characteristics of the cystic lesions of the pancreas, cysts, cystadenomas, IPMNs, those class. Also neuroendocrine tumors, SPENs, and then very rarely pancreatic mets to the pancreatic head. In the duodenum, things that can originate from there is just also quite uncommon. Just originates from that interstitial cells of Cardinal, like in the layers of the duodenum, out the third layer of the muscularis, and then rare malignant mass-forming lesions like leiomyosarcomas and duodenal lymphomas may infiltrate, although they're also quite rare. And then more benign lesions like your leiomyoadenomas, or your polyps may involve that space due to a large size. And then one should just take into consideration the relationship to the ampullary complex, which may necessitate a Whipple, depending. So it is quite difficult often to know where the lesions are actually coming from. So these are just 2 points to help one try and figure out. So look at the epicenter of the lesion. If it's in a pancreatic duodenal groove, if it's originating from there, it will cause expansion of the space between the pancreas and the duodenum. If the pancreas and duodenum is going in the same direction, one should consider that it originated outside. But that's not always easy. Especially with infiltrating lesions, one can look at the ancillary findings that could help. So that's your lymphadenopathy, things like air within the region, hemorrhage or fistulization upstream, duct irregularity, and things like that. So those are 2 small points to try and help differentiate where it's coming from. Thank you. Thank you very much.
Thank you very much, Gercois, for that very nice overview. I don't know if there are any questions. We've got a few minutes for that. I see there's maybe one in the chat. Let me just get it up here. Oh no, it was just the notice from Echo India. Any questions or comments? Sorry, I hear somebody there. Is it a question? I think they're just talking. All right. So if no questions, thank you very much, Gercois, for this very complete overview. Also, thanks to ECHO, University of New Mexico, and the ECHO Team India and the Gastro Foundation to make this possible. If there's any feedback that you want to give, you can give it in the chat space after the session. And then the next session will actually be, we'll skip 2 weeks due to the Association of Surgeons and Sages meeting next weekend. and also a public holiday. So the next meeting will be on colorectal, and we will be coming with a topic closer to the date. So for the next 2 weeks, no meeting. So in 3 weeks, we'll see again. All right. Thank you very much.
Thank you.